Hi, this is Brian Kim. I'm going to share with you this case of a fairly dense cataract. I did this person's first eye and was found to have some zonular dehiscence, supratemporal. I placed an AR-40 lens in a sulcus with optic capture, which turned out just fine. Fortunately, I did not have any vitreous loss. And then I thought to myself, did I cause that zonular dehiscence? I was not confident that that was the case, but it was in the back of my mind. And then I did this patient's second eye, and you'll be able to see what happens as this case progresses. So I use a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size the rexus. This is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. I'm using the Orlock technique to twist the incision with the cannula. This is the left eye. I'm turning the eye down. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. Using that cannula to hold the eye with the Orlock technique, I go in with my microrexus forceps, puncture the center, pull down towards me, grabbing the right side of the tear. Again, trying to make a rexus similar to the size and centration of the mark that I made previously. The cannula gives me great control of the eye while I do the rexus. And again, if I lose more OVD, I can push more OVD simultaneously. So I'm using minimal movements in and out of the eye and using the instruments that I have in the eye to my advantage. Finish off the rexus. And this is the capsule fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, decompress the bag. You can see the lens is a little bit more mobile now. Irrigating the surface of the eye, adjusting the sleeve. And again, this is a Veritas vision system. It's an excellent phaco machine, great chamber stability, excellent fluidics, and a very powerful ultrasonic machine. Removing the surface epinuclear material, sliding the chopper under the rexus edge contra-incisionally, the phaco tip vertically sub-incisionally, bringing the instruments together and fracturing the lens with manual forces. That's double chop, sliding the chopper under the right heminucleus, hooking the peripheral lens, pulling it central toward the phaco tip, and fracturing the right heminucleus in half, and that is the cross chop using manual forces. I tried to use vacuum to lift that first quadrant up. It wouldn't come, and clearly it's because it's stuck. So I perform another cross chop maneuver, doing a little bit more of aggressive chop, and then you can see it fracture. Grabbing that fragment up and then emulsifying it. Now you can see that first quadrant's nice and loose, and it comes up with some vacuum, flanking the lens with the instruments and crushing it with manual forces, and then fluttering the foot pedal to use some sparing amounts of ultrasonic energy to emulsify the lens pieces. Turning the second heminucleus in front of me, very gently, sliding the chopper under the lens in the periphery, pulling it centrally toward the phaco tip. The phaco tip is deep, and I'm able to crush the lens in half, using some vacuum to grab that third quadrant, and then holding it, and then getting around it with the chopper, crushing it with manual forces, and emulsifying the lens piece. And this is the final quadrant, doing the same thing, sliding the chopper under the rexus edge, pulling it centrally toward the phaco tip, fracturing it once again, and then getting around the lens piece with the instruments, crushing it again with manual forces, and then fluttering the foot pedal to emulsify the lens pieces. Again, using sparing amounts of ultrasonic energy and being strategic. When I fracture the lens with manual fracturing techniques, I don't use any ultrasonic energy or vacuum. Minimizing ultrasonic energy helps maintain clear corneas postoperatively. And this is the final piece. Use some vacuum to grab it, but it wouldn't come forward. So I'm using the chopper to gently slide it up. That doesn't work. So then I just want to be really careful here. So I'm using some vacuum to just grab that last quadrant up out of the bag. Again, just being very careful to grab the endonucleus and not the epinucleus. Again, because this patient had zonular disease, I didn't want to accidentally grab the anterior capsule or do something funny. Again, because that first case had that zonular problem, I did not want to do anything that could contribute or exacerbate that problem. So again, you can see with my maneuvers and just what I'm doing, you can tell that I'm just being super careful on this eye. Again, it's because there was a problem with the second eye. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece, adjusting the sleeve, starting subincisionally, peeling from anterior to posterior, and as I pull, take a look. As I pull, you can see there's complete loss of zonular integrity. You can see the capsule fornix coming forward. So I release it with reflux and I go to a different location. And I know I didn't cause this abnormality. So again, the first eye, which was the right eye, I noticed supratemporal dehiscence. And lo and behold, in this patient, the left eye, there is supratemporal dehiscence as well. So a bit strange. At least the patient's eyes are consistent, and there's a little bit of zonular weakness supratemporally in both eyes. But again, this tells me there's something not quite right with this patient's anatomy, and it's not because there was some iatrogenic cause of the zonulopathy. You can see I'm doing side-to-side movements, just grabbing the cortex and trying to pull it tangentially, which will minimize any focal stress on the zonules. And then I go back, start peeling along the inferior cortex here, making sure I grab the anterior cortex as I go. Just, again, pretty loose right here, being very careful. And we're dealing with the temporal zonulopathy. It's a little tricky because my incision is also temporal, so it's all subincisional action that I'm dealing with. Again, foot pedal control is of utmost importance here. You want to be very, very careful, very light-footed as you try to peel this stuff off. So as you see, I'm pulling. You can see some stria in the peripheral capsule right here. As I look back at the case, I even saw stria superior temporal, like I was saying, but clearly it's all this temporal quadrant where there's some zonulopathy. I think this might be when I first noticed it, but again, in reviewing the video, I did notice some of that weak zonulopathy. I did notice the zonulopathy before, primarily in the supratemporal location. So I'm using a BSS cannula with infusion on, and I'm just using the BSS cannula to simultaneously pulse BSS into the subincisional capsule fornix to see if I can loosen that stuff up. Because if I just pull, you can see the stria that's forming in the peripheral capsule. I don't really want to stress the zonules. You can see it's just very, very, very carefully trying to peel that stuff off. And again, pulling from the, you can right there, you can see it. As I'm trying to pull, there's clearly some focal weakness right here. It's all the same area, just that temporal quadrant is focalized zonular dehiscence. I'm grabbing and trying to peel simultaneously using that BSS cannula. So I'm able to pull the rest of that off. And then I just quit at this point. I just turn off infusion, push some cohesive viscoelastic to fill the bag. And then I'm going to pulse with my right-angled hydrodissection cannula into the subincisional space, see if I can loosen some of that up. I'm not going to perseverate too much. I can always deal with that cortex later, but I'm trying to loosen it up with my hydrodissection cannula. Again, because this is a cohesive, you can see all that stuff coming out. So fill the bag up again, and this is the capsular retention ring. I like to lift it up out of the inset area, lift it up on the platform, and then hooking it from the left eyelet so it goes into the injector counterclockwise so that when I push it out, it'll come out clockwise. Lifting the incision with the Lester hook. Pushing some more cohesive viscoelastic to fill the bag. Going back to the Lester. And then I'm going to inject the CTR using the Lester to hook the leading eyelet. And by doing it this way, I'm able to compress the CTR so it limits the diameter. As it goes in, it limits traction on the capsular bag. So now it's completely in. And now I'm going to do a dry aspiration technique. I'm using a 27 gauge cannula. I'm trying to gently tease the cortex out of the capsular fornix. So it's a dry aspiration technique. Okay, I think that's enough. Fill the bag with some more cohesive viscoelastic. And this is the single piece acrylic lens, the ZC-BOO. This incision is a 2.4. It's a little bit tight for this injector. A 2.6 is probably better for that. Filling the bag with more cohesive viscoelastic because with that pressure it burped more viscoelastic out. And then using the cannula to quickly disengage the haptics off the optic, making sure that both haptics and the optic are inside the bag. And then I'm going to go in with irrigation off, adjusting the sleeve. Adjusting my bottle height. I just brought the bottle height down a little bit. Gently going underneath the lens to remove any viscoelastic from within the bag. Polishing under the rhexis edge, removing the viscoelastic from the anterior chamber. Again, I'm on a low flow setting here as well, and then I'll hydrate my incisions. So again, this is a patient who had zonulopathy. The first eye, I wasn't quite sure if I was the cause for the zonulopathy. It was superior temporal. I put the lens, a Sensar AR40 lens, in a sulcus with optic capture. I was worried that there might be vitreous, but fortunately there was no vitreous in that case. And then I asked myself for the second eye, is this going to happen again? I was very mindful that maybe it could happen. Was it something that I did, or is this something that was going on with the patient? But as I discovered, once I started doing INA, you can clearly see there's some temporal zonular dehiscence. As I was trying to pull the cortex out, you can see the posterior capsule started to collapse. The capsular fornix started to collapse in with the forces of the INA. So I was very careful in peeling that stuff off. I tried to do dry aspiration. I did some more hydrodissection. And then finally, I put in a capsular retention ring using the Lester to compress the diameter of the CTR. And then I put the single piece acrylic lens in the bag. So I hope this was helpful to you. And I thank you for your attention.